Hello everyone. Hello everyone. This is Dr. Sandeep Madaan. I am an anatomy faculty at DAMS. Particularly this time, it was a little hard for you to prepare for your exam because of the ongoing pandemic and the hardships associated with it. But somehow, with your hard work, with your commitment, you could do it. So, right, and I have anatomy questions which were asked in this exam. These are purely on the recall basis. So you may find there are certain differences between the options which you may feel like these are not there in the real question paper. That is fine because as I told, these are only record based. But we also know that more than the questions, basically the topics or the concepts are more important, right? So let us begin with the questions. This is the first question which was based on the branches of the axillary artery, and few branches were marked, and it was asked which one is wrongly marked here. So before coming to the question, let us talk about the branches of the axillary artery. Now in our classes also I have given certain mnemonics at various places, and for the axillary artery also I have given the mnemonics in the regular classes. Now, if you look at this part here, axillary artery is divided into three parts. Like this is first part, which is proximal to the muscle. This is the pectoralis minor muscle. This is pectoralis minor muscle, and proximal to it, part one of the artery. Beneath it or behind it is part two, and distal to it is part three. So these are the three parts of the axillary artery. Now let us talk about what are the branches from these parts of the axillary artery. To remember that we know the mnemonic, and just before that these are the three parts of the artery, and as we know, from the first part one branch comes out, from the second part two branches, and from the third part three branches are there, right? And what is the mnemonic? Mnemonic goes like salt spa. What is the mnemonic? Salt spa, right? So from the first part only one branch, from the second part two branches, right? This T is common. What is the meaning of T? Is thoracic. Now how to use this mnemonic? See, S for superior, add T, that is thoracic. So it becomes superior thoracic. A is acromio, again add T, acromio thoracic. Then L is lateral, add T is thoracic. So superior thoracic is a branch from the first part, acromiothoracic and the lateral thoracic are the branches from the second part. Now we are left with these three branches, S, B, and A. What are these branches? S is subscapular, and P and A are nothing but Pacha and Acha. What is Pacha Acha? These are nothing but posterior and anterior circumflex humeral arteries. Right? So these are the branches from different parts of axillary artery. Let us now talk about these branches here. See, what has been marked as A, this one is nothing but superior thoracic artery. And what has been marked B, this branch here, let me zoom in and show you. This is nothing but acromiothoracic artery, and acromiothoracic artery is actually giving certain branches to the pectoral part here, to the acromial part, to the deltoid part, and also it gives the clavicular part. So this is acromiothoracic artery, which further gives four branches, right? Now there is one branch here which actually is given from the second part of the axillary artery. As we know, it gives two branches from the second part, acromiothoracic and the lateral thoracic. Acromiothoracic we just now learned. Lateral thoracic is which passes beneath and it comes out on the lateral aspect of the pectoralis minor. This is lateral thoracic artery. And from the third part here, this artery which has been marked B is nothing but subscapular, and here if you can see around this part here, these are Pacha, that is posterior and anterior circumflex humeral artery, right? So now we know what is the meaning of this ABCD. Our A is superior thoracic artery, yes. B is acromiothoracic, correct. C is lateral thoracic, that is also true. D is not Pacha, rather D is subscapular in this given question. So answer to this question is D, right? Now let us move to the next question. And we have been given this muscle, and it very easy. It has been asked what is the name of the muscle. Now we know this muscle is pretty obvious thing from the genioglossus. Here, this muscle is going to the tongue, so it has to be genioglossus. It has to be genioglossus. We appreciate this muscle is genioglossus muscle. Now, this muscle, another important point about this muscle is responsible for the protrusion of the tongue, right? For the protrusion of the tongue. So, when the patient is in coma or this muscle is not working, then the tongue may roll back and it may block the airway, right? So whenever you are examining a patient in an emergency ward, you must ensure the airway is patent, right? Because genioglossus in normal circumstances prevents the blockage of airways. That is why it is called as safety muscle of tongue, right? Coming to the next question. Next question is, all of the following are paired except. Now, this is again very easy question. All of the we know the laryngeal cartilages are paired and unpaired, right? What are the paired cartilages? Cuneiform, corniculate, arytenoid, and one more cruciate. These are the paired cartilages. And what are the unpaired cartilages? Thyroid, cricoid, and epiglottis. So answer to this question is thyroid cartilage. Straightforward question, right? Next question, which of the following is abductor of the vocal cord? Now this question has been asked number of times and also it has got you see the clinical importance. Only abductor of the vocal cord is PCA muscle, that is posterior cricoarytenoid muscle, and this is posterior cricoarytenoid because it can abduct the vocal cord. If the vocal cords are abducted, through the gap between them, the air can pass, and because of that, the respiration is possible. Okay, as I told, to keep the airway patent, vocal cord also must be abducted. Okay, if they are abducted, then the air can't pass through them. So obviously, for the same reason, this muscle is called as safety muscle of larynx. So we have discussed safety muscle of tongue and the safety muscle of larynx, right? Now let us look at the muscles of the larynx in this diagram. What we can see here, this is the arytenoid part here. Okay, this is the arytenoid. This is arytenoid. This is the cricoid. Anterior, it is less wide. Posterior, very big. So this part is the cricoid part. Okay, and above it we can see this is arytenoid. This is arytenoid. Alright. Now you see this muscle is actually going from where? From the posterior aspect of cricoid approaching towards the arytenoid. So it can be called as posterior cricoarytenoid. The same muscle in the lateral view is visible like this. This muscle is coming from the posterior aspect of the cricoid reaching the arytenoid. So it has to be PCA. And what about this muscle? It is coming from the lateral aspect of the cricoid and going to the arytenoid. It has to be LCA, lateral cricoarytenoid. And this muscle is vocalis muscle, right? What about these muscles? This is oblique arytenoid, which is connecting the arytenoids, but in the oblique manner. And this muscle here, you can see, is the transverse arytenoid. And the transverse arytenoid is the only unpaired muscle here, right? It is the central muscle. But in this is thyroarytenoid. So these are the muscles of larynx, and as we have discussed, PCA is the only abductor of the vocal cord. Coming to the next question, this section. It has been asked in number of exams and number of times. Okay, maybe AIIMS, when AIIMS used to conduct the exam separately, now the central exams are being taken together. But anyway, this particular section, based on the basal nuclei, based on the thalamus, the DAX segregation, this has been asked number of times. So when in the classes also, I have asked you to pay attention to this section carefully, and I have emphasized while discussing this, right? This was a simple question with respect to the discussion that we have already done in the classes. Anyway, let us look at this. So what is A? A is nothing but the caudate nucleus. This is caudate nucleus, right? And this here is the lentiform nucleus because it gives the appearance of the lens. Now we know that this caudate nucleus and the outer part of the lentiform. This is outer part of the lentiform that is a little darker. It is called as putamen. So caudate and putamen are connected together with the help of these striations. Because they are connected with the help of striations together, these two nuclei, that means caudate as well as putamen, together it is called as striatum or neostriatum. Together it is called as striatum or neostriatum. Alright, this is one part. And here you can see, if I draw the lentiform nucleus again, the inner part of the lentiform, it looks paler in the section, right? So that is why it is called as pallidum. What is this nucleus? Globus pallidus. What is this? Is putamen. So putamen and globus pallidus together is called as lentiform nucleus. Alright. Now, what about this nuclei? These two are thalami, left and right thalami. Between them, the gap is the ventricle. Which ventricle? Third ventricle. This is third ventricle. Alright. This is third ventricle here. This is lateral ventricle. This is also lateral ventricle on this side. This part, what you can see, is the corpus callosum. Okay. Septum pellucidum, fornix. Alright, and with respect to lateral ventricle, if you see, the caudate and thalamus is making the floor. Right, see this. This is the lateral ventricle, caudate and thalamus are lying along the floor. Okay. Now, after having discussed these, what else we can see? We can see the white matter. This is the white matter which is passing between caudate, lentiform and the thalamus. What is this white matter? This is nothing but internal capsule. And what about these? What is this which has been marked B? Is the insular cortex or the insula. Why it is called as insula? Because in the initial period, what happens that our brain matter is like this, but later the brain is going at very fast rate than the containing cranial cavity. So brain undergoes certain convolutions, and what really happens, one part of it goes inside like this. So if you look at this part now and you take a section here, this section here will show the layers of the cortex. This section also, here also it shows the layer of the cortex. But if you take a section here, it will not show the layer of the cortex. Why? Because it is deeper, not at the cortex level. But again, if you take a section here, it will show the layers of the cortex. But why it is showing the layer of the cortex? Because its position is very deep with respect to it. Yes. But it is just like an island. Island is just like the main mass of the land, but it is separated from the main mass by the, you see, water. Similarly, this part of the cortex is actually a part of the original cortex only, but now from the surface it has gone deeper because of this arrangement. So it gives the appearance of island. That is why it is called as insula. That is why it is called as insula, because it is just like, it is a part of cortex only. So it will show the layers of cortex. So there is no difference, right? But only thing is it has gone deeper. That is why it has been given a separate name. It is called as insula. Now we know the labeling of this diagram. Let us go back to the question. A is the caudate nucleus. So yes. B is thalamus, that is true. C is lentiform, true. D is insula, not the internal capsule. Answer to this question is D. Right? Next question is this. All are true about thoracolumbar fascia except. Now let us discuss about the thoracolumbar fascia and then we'll come back to the question. Now when you talk about the thoracolumbar fascia, where exactly it is present and how it is present, let me describe this part to you. See, this is the vertebra and this part is the spinous process and this part is the transverse process of the vertebra, right? We appreciate. Now, along the transverse process, okay, this part here, this is the posterior abdominal wall. This muscle and these muscles, these are actually lying along the posterior abdominal wall. But behind the transverse process, that means this region is actually back of the body, not the posterior abdominal wall, but the back of the body, right? Or you can see the dorsal body wall, not the back posterior wall of the abdomen, right? Rather, it is the posterior wall of the body itself, which we call as the back of the body, or other way around, we call it as the postural muscles, right? Or erector spinae group. So, what is this muscle here? This muscle is erector spinae, which belongs to the postural muscles. Is that clear? Now, along the posterior wall of abdomen, this muscle is psoas major. What is this? Psoas major. And this muscle is quadratus lumborum, right? Now let me add the facial layers. Here you can see this is one fascia which is covering the psoas major. It is called as psoas fascia. And there is another fascia here which is actually covering by the anterior layer, and this is the middle layer, anterior layer and the middle layer of thoracolumbar fascia, and this is the posterior layer of thoracolumbar fascia. Do you appreciate? So this is how it is present. So it is attached to the transverse process, also it is attached to the spinous process. And what are the layers? This is anterior layer, this is middle layer, and this one is posterior layer. 3 layers of thoracolumbar fascia. What is the name of the fascia? Thoracolumbar fascia. And on the other side, it is giving attachment to these 2 muscles. What are these 2 muscles? This is, if you look at the labeling on this part here, this is external oblique, internal oblique, and transversus abdominis. Now here we can see it is attached to the transversus abdominis and internal oblique, but not to the external oblique, right? This fascia here is thoracolumbar fascia. This is thoracolumbar fascia. Is that clear? Right? Let us go back to the question now. Understand? Is it attached to the spinous process of the lumbar vertebra? Definitely it is attached. Is it attached to the transverse process of the lumbar vertebra? It is attached. These are true statements. The fascia lies posterior to the posterior abdominal wall muscles. That is also true. But it's not entirely true because it also lies anterior to the posterior abdominal wall muscle. Because one of the muscle, posterior abdominal wall muscle, is quadratus lumborum, so it covers anterior and posterior, right? Next choice is gives attachment to transverse abdominis and the internal oblique muscle. That is true. So 3 choices are completely alright, but one choice is not exactly true. So that will be the answer to this question. This fascia, it lies anterior as well as posterior to the posterior abdominal wall muscle, right? Next question, injury to the bulbar urethra leads to extravasation of urine in all of the following except, and choices are superficial perineal pouch, deep perineal pouch, scrotum, and the thigh. So let us discuss about this area and the extravasation of the urine. Now understand this part. This is a section through the perineal region, and here you can see these 3 fascia particularly. This is superior fascia of the urogenital diaphragm, this is inferior fascia of the urogenital diaphragm, and this is the collis fascia. So basically in between these 3 fascia, you have 2 spaces. What are the 2 spaces present? This is what is called as deep perineal pouch. And this is what is called as superficial perineal pouch. You appreciate, right? Now, this is urinary bladder. From the urinary bladder, this is urethra. But this urethra is actually contained within the prostate. So this has to be called as prostatic urethra. So what is this urethra? This is prostatic urethra. What about this layer? This part of the urethra. This part of the urethra is called as membranous urethra because it pierces this membrane here. What is this membrane? This membrane is actually perineal membrane. What is this membrane? This is perineal membrane. And this is nothing but the inferior fascia of the urogenital diaphragm. Actually, inferior fascia of urogenital diaphragm is too thick. We call it as membrane. So this is perineal membrane. It is pierced by the membranous urethra. After that, this part here, this urethra shows certain dilatation. Okay, this is called as bulbar urethra. That means bulbar urethra is present where in the superficial perineal pouch. Now let us see the same thing from the lateral view or the sagittal view, and in this view we can see that you can say now this is the perineal pouch here, alright, and this part here is the collis fascia, alright. So basically what happens in case of injury of bulbar urethra here, suppose this part is gone, where the urine will go? Urine can go to the scrotal part, it can go to the penile shaft part, okay? It can also go to the anterior abdominal wall. Usual locations are scrotum, penile shaft, and also it goes to the anterior abdominal wall, little bit to the upper part of the thigh. Not all throughout the thigh, because let me explain one part here, that when we talk about the thigh, the membranous layer of the abdominal fascia, right, it is loosely attached up to this line. What is this line? Holden's line. It goes just lateral to the pubic tubercle. If you draw a line, this represents the Holden line. So up to this line, there's a loose attachment, but beyond this line, it's a firm attachment. Okay. So urine can come to the upper part of the thigh, but not beyond the Holden's line. Do you appreciate this part? Yes. But if we go back to this diagram and understand, that means we can say if there is extravasation because of the injury to this urethra, there will be collection of urine in the superficial perineal pouch, yes. There will be collection into the scrotum, anterior abdominal wall, yes. And it can go to the upper part of the thigh as well, above the Holden's line. But can it go to the deep perineal pouch? No, because deep perineal pouch is closed in all parts, right? So that is why answer to this question will be the extravasation won't be seen in the deep perineal pouch. Is that clear, right? Let us proceed and see the next question. Corticospinal tract versus head. Now this is a question which in different form is asked in different exams, right? Sometimes they ask like in you see in applied manner, okay, where they may talk about the Brown-Sequard syndrome, or sometimes they ask different type of questions on the tracks are asked, right? They may ask about the human injury, element type of injury. And right now, this was very easy. They simply ask where the corticospinal tract crosses, right? So as we know, the corticospinal tract, it begins from the cortex, right? When it comes down, it makes an internal capsule because of the very less space available between the thalamus and between the basal nuclei. We have already seen internal capsule. At that part, all the tracts are very much compressed, all the fibers are very close, and then it crosses the brainstem, that is midbrain, pons, and medulla. This is at the lower end of the medulla when it crosses or it decussates to the opposite side. So answer to this question is lower medulla, as we know, right? And then finally it reaches the spinal cord and it controls the anterior bone cells, right? Coming to the next question, Killian's dehiscence. Again, a straightforward question. Killian's dehiscence is seen between, as we know, answer is between the thyropharyngeus and the cricopharyngeus. What is Killian's dehiscence? Let us see. See, this is these part here is showing the pharynx muscles here, and this is the inferior constrictor. This is called as inferior constrictor of the pharynx, but it has got two parts. This part is thyropharyngeus and this part is cricopharyngeus. So between the thyropharyngeus and the cricopharyngeus, there is a gap of potential weakness. The gap of potential weakness, let me show you here. Right here you can appreciate the inferior constrictor in the form of thyropharyngeus. Again you can see the cricopharyngeus. Cricopharyngeus will continue with the esophagus here. Do you appreciate? So this is cricopharyngeus, thyropharyngeus, esophagus. Now this gap of potential weakness between the thyropharyngeus and the cricopharyngeus is called as Killian's dehiscence, right? Why do you say gap of potential weakness? Because normally when the thyropharyngeus is contracting, the crico will relax. Both of them are not contracting at the same time. This happens like to ensure the peristalsis goes from proximal to the distal direction. But if there is incoordination, both the muscles are contracting together, then there will be huge pressure located inside. It will lead to Zenker's diverticulum, right? So answer to this question is thyropharyngeus and cricopharyngeus, right? Now after this, there were two questions which were actually, you can say it had the overlap between anatomy and the radiology. Or you can say it was asked on radiological anatomy, right? Now this question was based on the epidural hemorrhage. I could not get the options properly, but this question was made on the epidural hemorrhage, and basically this such type of image was shown where you can see the convex type of collection here, right? This is a typical feature of the epidural hemorrhage, right? Other radiological features will be, discussed in the, must have been discussed in the radiology classes. But what I want you to understand is the anatomical part here, right? Now, just before the discussion of that part, let me just show you how the subdural and the epidural, there is difference between them. Let us see. Epidural will show like convex, biconvex, whereas subdural will show crescentic. Okay, if you see the crescentic hemorrhagic lesion is subdural and convex will be epidural. And one more thing, epidural bleed is arterial bleed. What is the most common vessel? Middle meningeal artery, right? And what about the subdural bleed? That is the venous bleed, venous collection. If you remember, below the dura part, or you can say the dural venous sinuses, right? So just below the dura we have the dural venous sinuses. So subdural hemorrhage is usually the venous blood, and the most common cause of the subdural hemorrhage is also veins, right? So these are the vessels that we should always remember. Extradural hemorrhage, middle meningeal artery. Subdural hemorrhage, the bridging veins, which is nothing but the superior cerebral veins. Subarachnoid hemorrhage is perianeurysm. Further inside, intracerebral bleed, Charcot's artery of the cerebral hemorrhage. What is Charcot artery? It's a branch of the middle cerebral artery. Which branch? Lenticulostriate, which supplies the lenticular nucleus and the striatum. Right? So that region that we have already discussed in the cross section, that is the artery supplying that region is called as Charcot artery, which is the most common artery for the intracerebral bleed. Right? Now, middle meningeal artery, when we discussed in our classes, I told you about some points about the middle meningeal artery. What were these points? See, middle meningeal artery passes through the two roots of the nerve is there. Which nerve? Auriculotemporal. You remember auriculotemporal nerve, between the two roots of auriculotemporal and middle meningeal artery will pass. Second point, it passes through foramen spinosum. What are the structure passing through foramen spinosum? Men. Middle meningeal artery, hemispheric vein, nervous spinosum. Fine. And after that, it is seen deep to pterion. That is also asked. That has been asked number of times. Deep to pterion, which vessel is there? Okay. And the last point, most common cause of extradural hemorrhage. Okay. So these are 3-4 points about middle meningeal artery that you should never forget. Right. Let us now move to the next question. Again, the next question is from the radiological anatomy. This was based on this congenital diaphragmatic hernia. So this image was shown where you have the bowel loops above the diaphragm. How it is possible? Let me show you like this. So this is how, if there is a defect in the diaphragm, part of liver or any part which is below the diaphragm may enter through that gap. Right? This is what is called as congenital diaphragmatic hernia. To understand that, let us discuss the embryology of the formation of the diaphragm. See, here we can see the initially we have this part here that we have septum transversum, right? We have septum transversum here. We have the dorsal mesentery of the esophagus, and here you can see the pleuroperitoneal fold. But at this stage, you can see there is a canal, pleuroperitoneal canal. Why? Because at this stage we have the communication between the thoracic and the diaphragm, thoracic and the abdominal cavity, right? They are not completely cut off. But later what happens, this pleuroperitoneal fold will seal the defect by making the pleuroperitoneal membrane. In the next diagram here you can see the pleuroperitoneal membrane has sealed the defect. It is just like if you want to divide a room by making a wall across the room. But instead of making a brick wall, initially you put a cardboard. Okay, even if you put a cardboard, it will divide the room into two small rooms, but it will not be a thick wall, right? Similarly, here we have a membrane, but over this membrane, some solid structure should come, some strong structure should come. What is that strong structure? We know the muscles. Now the muscles are the migratory muscles. These are called as cervical myotomes because they are coming from the cervical part. That is why they are carrying their nerve also. Have you ever imagined that diaphragm being between the thorax and the abdomen? Why it is supplied from the cervical segments? What is the nerve supply? Phrenic nerve. What is the segment? C3, 4, 5. So location of the diaphragm is here between the thorax and the abdomen, but it is supplied by the cervical region. Why? Because The myotomes, they migrate and they carry their nerve supply. That is why, right? So we know now that the cervical myotomes will come and they will spread and finally they will make the large peripheral part. So eventually what really happens that you have the septum transversum which will make the central tendon of the diaphragm. You had the dorsal uh, mesentery of the esophagus, which is now making the crura. These are the crura. What about peripheral part? We know the membrane is making a little bit contribution. Mainly it is the muscular part. Which muscle? Cervical myotomes. I hope that part is clear. But this chloroperitoneal membrane, the small part contribution, sometimes it remains defective. So this is where congenital diaphragmatic hernia develops. Is that clear? Just to summarize this is how it happened, right? So first there was a gap, then the gap was sealed, there's no gap, and then the muscles started coming from outside, right? So these were the questions which I could get from the students, right? So best wishes from my side, okay? And this is my Facebook page, and Insta, and the Telegram group detail. You can join me for further discussions. Thank you very much, everyone. All the best.